Now it's time for questions and discussion. So please reach the microphone if you have questions.
Yes, thank you very much for your wonderful talks. I have a question to Paola regarding the first patient. Our common choice was to switch this patient to momelotinib. And what would you do if, after several months, the patient will have A, not optimal response, B, progressed, since she declined the allogeneic transplantation? What would you do?
In patients that switch to momelotinib, I think that in those patients in which is indicated transplant, we need to stress that the transplant is the only option to cure this disease.
She was ASX1 positive, right?
We know, obviously, this is a possible indicator that JAK inhibitors, especially for ruxolitinib, we have no other information for the other JAK inhibitors, is associated with a greater rate of discontinuation. So in that case, probably the choice of the transplant should be the first. Often, I think it's a usual consideration. Patients that have no enough symptoms or no huge spleen sometimes refuse transplant and prefer to start a drug. But obviously, we have to stress it.
Can I add a comment on this point? So we at the last ASH meeting, we provide evidence from a large cohort of patients. The first name was Nico Gagelman on a transplant indication in a large population who received JAK inhibitor. And the study that is complex from a statistical point of view indicated that stem cell transplant is really indicated in some situation with a specific delay from the time of diagnosis. So basically, I fully agree with Professor Guglielmelli. So the indication is stem cell transplant, yes. So proceed to achieve the better response of the spleen, symptomatology, and so on, but proceed with stem cell transplant because the evidence is that in specific condition with a good donor, for instance, because also the MTSS must be calculated. So the balance between MySEC, DIPS, MIPS, MIP70 versus MTSS are quite important, but I fully agree with the comment of Paola.
And there is also data that are recently proposed by the French group that if you combine MTTS in intermediate categories of MIPS, intermediate one of DIPS, may have a benefit in terms of transplant compared to do not make a transplant. So.
Yes, thank you. And regarding the third patient, the third patient had anemia, but mild anemia with hemoglobin level of 10.2. And the low platelet count 87 or something like this. What do you think about the fedratinib? Because if you use ruxolitinib, you have to adjust to the platelet count, so the doses must be low. And in fedratinib, you could use the full dose in this patient. What do you think about this?
I think what's your aims in this patient, in particular, what is the aspect, the more impact of the quality of life of this patient, that I think in this case is the splenomegaly. Fedratinib should be a good option in this case, considering that they have the possibility to reduce the hemoglobin level and the platelet, and so it considered that if this is acceptable for patient, they maintain this drug. But it's an option, obviously.
Thank you.
Thank you. Professor Harrison.
Thank you so much. Congratulations, brilliant session. May I ask a question about iron chelation for the management of these patients? Does the panel have a particular policy? Because I think it's a little bit unclear for us in managing the patients that need transfusions. Do you use it? When do you start? What would you use? What's your target? Thank you.
Francesco.
Okay. I think that also in this case we have personalized the treatment. If the patient have the possibility to go to the transplant, I think it's necessary to start in order to reduce the toxicity of iron accumulation and so on. In older patients, we need to balance the toxicity of the treatment in terms of renal toxicity and to evaluate if a good option to improve the quality of life of these patients.
I just have the same approach, especially in patients who candidate to stem cell transplant, but also in other patients. And the indication is according to the label and the reimbursement criteria. So patient who receive transfusion with a high ferritin level. And there are also, I think, 2 or 3 retrospective analyses that demonstrate retrospectively, of course, that you can also increase erythropoiesis, so you can have a positive effect on anemia using iron chelator. So I think that is an important point, but the renal impairment is a very important point, especially, for instance, if you use some drugs that can have an effect on renal impairment, such as fedratinib, for instance, on few cases also momelotinib.
I think the aim is to delay the possible to the transplant transfusion dependency.
Thank you for your presentation. One question could be, what could be the drug survival, not the patient survival? The drug survival you have for drugs, basically the distinction between one versus the other is subtle, because sometimes you prefer momelotinib because the anemia, but each of these drugs has some toxicities. So the termination should be taken into account. I don't know how long can be treated a patient with a single drug. So I think this is another criteria to put into consideration when you start a treatment in a patient with myelofibrosis. And if you decide that, you should have a backup after each of these drugs you started with. What do you think? This policy of treatment by keeping in consideration that all these drugs can be active.
This is an excellent point, Tiziano. Thank you so much. We know that in general, the evidence we have on the effect on survival is mainly related to ruxolitinib. So we have a demonstration, some retrospective, some prospective analysis that you can have an impact on survival. And we have a demonstration on PFS in the second line with fedratinib and momelotinib. But your question is the time on treatment. Of course, the longer the time on treatment, probably the best will be the efficacy and the effect on survival. But the point is that what is better, for instance, take the case of ruxolitinib. So if you want to keep and obtain a deeper spleen response, you have to use higher dose of ruxolitinib. If you use higher dose of ruxolitinib, you induce more anemia. And so you say, this is anemia related to ruxolitinib, so I have to switch therapy, or I have to add on something. Okay? So in this case, to change therapy. But this is the reason why you want to reduce spleen. If you manage this patient with lower dose of ruxolitinib, you achieve lesser response of the spleen, and probably you keep the patient longer with ruxolitinib. But we have to keep in mind that we have to look at endpoints with an impact on overall survival. So in my view, it's better to insist with higher dose of ruxolitinib, for instance, obtain a spleen volume reduction, and then manage the issue of anemia. But I fully agree that probably Ruxo is a JAK1, JAK2 inhibitor very similar to the other JAK inhibitors. So the reasoning about the time on treatment is true for Ruxo, but true also for Federate and so on. But the rate of side effect that you can have with other drugs, of course, are responsible for the rate of discontinuation.
Yes.
So the patient profile for this decision is quite relevant. Thank you, Tiziano, for this very important question.
Thank you. There are also questions about are there any future therapies in or combination that you believe could improve outcome for patients with MF and anemia? Maybe Francesco?
We have no, I think for the time being, we have no information about the combo and the overall survival. We have the information that for those patients who achieve more than 20% reduction in VAF with navitoclax plus Ruxo in the first line, live longer than those who did not. The same is true also for the second line. But what I see that we are working on, for instance, the dual responses. So, for instance, the rate of dual responses, symptoms, and spleen seems to be higher with some combo respect to single agent. And so we have probably to see if the achievement of dual response may be impactful on the overall survival of patient. But we need more time, a longer follow-up to be conclusive on this.
And any new agents that could improve anemia in combo with Rux?
Yes, there are data about the combination with pelabresib, for example, that in patients who are already treated with ruxolitinib achieve about 25-30% of responding spleen, and also in increase in anemia in this patient, and probably another possible combination that can be used in the future is the combination of ruxolitinib and luspatercept, that in those patients, especially treated and maintaining treated with ruxolitinib, obtain a reduction of more than 50% of transfusion and about 30% of transfusion independency. So these maybe are the most favorable combination in the future.
Thank you. There are many questions. I apologize. We will not have the time to answer. Just one last question, maybe in line with this previous one. How do you decide between using an anemia supporting agent on top of ruxolitinib for patients who develop anemia rather than switching to another single agent?
This is a not easy question because for the time being we are not yet approved and reimbursed for Italy, for instance, anti-anemic agents. So we hope that the independent study will demonstrate an advantage of luspatercept, so then we will decide. But in my view at the moment, if you have a patient, for instance, who start with ruxolitinib, and this patient keep spleen and symptomatology control and remain anemic, this is a patient candidate to luspatercept, risankizumab of DISC 0749. So for treatment against anemia, because the disease is controlled in terms of symptoms spleen, but we have anemia. The second case is a patient who loses spleen response, symptomatology, and anemia. So in this case, you need an alternative JAK inhibitor. This is what I think that I will do in my practice.
Yes, I completely agree. I think that if my focus is to maintain or reduce the spleen, a huge spleen, I have to add something to the first JAK inhibitors that probably is ruxolitinib. But if patient lose response or have a suboptimal response, we have to switch.